Hi, my name is William Hucker, and I am a cardiac electrophysiologist at Massachusetts General Hospital. And I am here today to talk to you about telemonitoring in atrial fibrillation. So the key takeaways for this talk are to review the role of cardiac rhythm monitoring in the detection and ongoing management of AFib. We'll also review the role of using implanted cardiac rhythm monitors in patients who have had a cryptogenic stroke. And we'll discuss the appropriate use of wearable technology in AFib management. AFib is a very prevalent condition, affecting more than 6 to 8 million Americans currently, and that number is projected to increase over the coming decades because of the aging population and the obesity epidemic. It also carries with it significant morbidity and mortality. Therefore, it makes sense intuitively to try screening for AFib and prevent the long-term consequences of the condition, namely strokes. So screening for AFib is becoming increasingly common, and largely because there's an explosion of devices that are available for this. This has allowed for longer-term monitoring than was previously available. However, one caveat to these monitoring devices is that we really have to verify the rhythm abnormalities present to make sure that the diagnosis is correct. There are many ambulatory monitoring options now for patients. There are consumer wearables. These are products that are widely available to patients, such as an Apple Watch or a Fitbit, and there are many others. The pros of these devices is that they're widely available, relatively inexpensive, and there's a high patient compliance because often patients want to wear these and look at their own data. But one of the cons of these devices and using them for AFib monitoring is for rhythm verification. The algorithms in these devices are largely based on irregular heart rhythms, and other rhythm abnormalities such as premature atrial contractions or premature ventricular contractions may be counted as AFib in these algorithms. But the monitoring for these devices can be long-term because patients can wear them for years. There are also consumer ECG devices available now, such as a Cardia or an Omron device, and these are also widely available. They suffer from the same potential problems with rhythm verification and falsely diagnosing AFib in the presence of an irregular rhythm for a different reason. But the monitoring for these devices is usually in 30-second intervals. A patient may feel palpitations and then put their fingers on the device to generate a rhythm strip, and then that rhythm strip can be verified by their physician. In terms of prescribed devices, there are patch monitors that are available. These can allow monitoring for days to weeks. Rhythm identification fidelity is very high with these, and all of these rhythm strips are reviewed by trained technicians or physicians. One of the cons of these devices is cost and that they're prescribed. However, they do provide relatively long-term monitoring up to weeks for patients in looking for AFib. And finally, there's implanted devices. These are made by major device companies such as Medtronic, Boston Scientific, Biotronic, etc. And they provide high rhythm fidelity rhythm monitoring where it's possible to monitor patients for years and look at whether or not they're having AFib. One of the cons of these devices is that they are implanted, so there are some small risks with that, and the cost associated with an implanted device. With all of the technology available to monitor for AFib, one question that needs to be considered is how long or how much AFib is required to need to be treated with anticoagulation. And this is a difficult question to answer, and it depends on the patient population. That said, I think it's an important message to deliver that relatively short atrial tachyarrhythmias may portend increased stroke risk for patients down the road. In the ASSERT trial, for instance, which was published in 2012, these investigators followed patients who had had a recent pacemaker or ICD or defibrillator implantation. And they looked for the detection by the device of a subclinical atrial arrhythmia in the first 3 months after implant. And they found 10% of these patients had an event of an atrial tachyarrhythmia detected in those 3 months. They defined the atrial tachyarrhythmia as having a heart rate or an atrial rate greater than 190 beats per minute and the arrhythmia had to last for greater than 6 minutes. And if patients met that criteria, then they were then followed afterwards. And they found that in these patients who had that arrhythmia, or an arrhythmia meeting those criteria in the first 3 months of the trial, that they had an increased risk of developing stroke or AFib down the road. Their risk of AFib was 5 times higher than those patients who didn't have an arrhythmia detected, and their risk of stroke was 2.5 times higher, those patients who did not have an atrial arrhythmia detected. So this suggests that even a relatively short atrial arrhythmia may portend increased stroke risk for patients down the road. In the Apple Heart study, this was a recent study that used Apple Watches for monitoring for an irregular heart rhythm. And they were able to enroll almost 500,000 participants in this study. And these patients were then alerted if their watch detected an irregular heart rhythm. If an irregular rhythm was detected, the patients were then sent a follow-up patch monitor to confirm the diagnosis of AFib. The positive predictive value for that was 0.84 for the diagnosis of atrial fibrillation. This showed that many patients can be screened effectively for AFib and that AFib will be detected. But the clinical outcomes of what that means for those patients moving forward in terms of earlier detection of AFib has not been reported yet. And so the real question is, does it make a clinical difference to pick up subclinical rhythms with an ambulatory monitor such as the Apple Watch? In other studies that have looked at AFib screening, they have not shown a large difference in outcomes for patients down the road. For instance, recently the STROKESTOP study was published. This looked at over 7,000 Swedish patients who had a CHA2DS2-VASc score of at least 3, and it screened them with a 1-lead ECG for 2 checks daily for 14 days. So a relatively short amount of time of screening for AFib daily, and then followed these patients long term. And they found that at 7-year follow-up, there was a borderline significant decrease in the primary outcome of stroke, bleeding, and death for the patients where AFib was detected and then treated. Similarly, in the LOOP study, this randomized patients ages 70 to 90 with an additional stroke risk factor to either having an ILR or implanted loop recorder placed versus usual care. And in that study, if they detected AFib for greater than 6 minutes, oral anticoagulation was started. Not surprisingly, in the group that had an implanted loop recorder placed, they found significantly more AFib. However, treating those patients made no difference long term in the outcome of decreased strokes. So the question of whether or not screening for AFib will make a large difference down the road is still an open question. In a different patient population, specifically patients that have had a cryptogenic stroke, AFib monitoring is routinely used. It's a guideline recommendation that patients who have had a cryptogenic stroke be monitored for AFib, but the duration is not specified. So this study called Crystal AF randomized patients to having an implanted loop recorder, or ILR, placed versus standard monitoring for AFib. And this study showed that by the end of the follow-up period at 3 years, almost 30% of patients who had an ILR placed had AFib detected. So that would argue that there is a significant amount of AFib in the population who have had a cryptogenic stroke, and therefore monitoring may be useful in diagnosing AFib in that population. Up till now, we've discussed using different monitoring technologies to diagnose AFib. However, once the diagnosis has been made, monitoring is often useful to track the effectiveness of interventions to treat AFib. For instance, many patients, after they've been diagnosed with AFib, will obtain a wearable or a consumer ECG device to be able to monitor for AFib at home. And these devices can be very helpful to monitor for AFib recurrence if a patient is on an antiarrhythmic, for example. To take this one step further, ILR monitoring can be used for monitoring treatment efficacy in AFib management. For instance, in the STROKESTOP study, which is presented here, this study used patients that had had an ILR implanted about a month before an AFib ablation to study the outcomes of 3 different ablation techniques. And what they showed is that with the ILR measuring AF burden before and after the ablation, they found a greater than 98% reduction in AFib burden with all 3 groups of different ablation strategies. So this shows that the ILR can monitor the efficacy of a treatment strategy and be used for patients long term. In some patients, this may be a strategy for stopping anticoagulation after ablation. However, the long-term safety of that strategy has not been validated. So in conclusion, the monitoring is here to stay in AFib management, and the ability to monitor and screen for AFib is rapidly expanding. Long-term monitoring has a higher rate of AFib diagnosis, and that's specifically true in cryptogenic stroke patients. And wearable and single-lead ECG devices allow patients to capture rhythm disturbances and aid in the long-term management of AFib. Thank you for your time and your attention. I hope you found this video educational.